So we'll talk about off-label use of clinically available TAVR valves for treatment of aortic regurgitation. And aortic valve regurgitation affects 2 to 2.5% of adults over 70 years of age. And there's multiple etiologies that we encounter in practice. We can have aortic root dilatation, a bicuspid aortic valve, calcified aortic disease with mixed stenosis and regurgitation, degenerative disease that's non-calcified, and also rheumatic heart disease. And many of these patients with a growing elderly population are at high risk for surgery, so we do need less invasive alternatives to surgical aortic valve replacement. So here's a case that I had recently. This was an 88-year-old man with heart failure, and he had had an echo after not having an echo for many years, and was found to have LV enlargement and a reduced EF of 30%. And then he had aortic regurgitation. You can see he had kind of sclerotic leaflets that were not severely calcified. And this is his TEE. And you can see significant aortic regurgitation hitting the base of the anterior leaflet. There were some degenerative strands on the aortic valve, so he underwent a workup for endocarditis, and that was negative. And so these were just thought to be degenerative changes of the leaflets. His TAVR CT, given that he was elderly and we thought he was increased risk, he underwent a TAVR CT, and these are some of his measurements. He had an area of 5.9 square centimeters, perimeter of 88, and he had a fairly large aortic root. He had good iliofemoral vasculature. So we decided to offer him off-label TAVR, and we decided on a core valve, 34 millimeters, which would provide us 21% oversizing. And this is his procedure. You can see the valve deployment over here on the left, and then after the valve was released. And this resulted in a good result. We had good sealing on the annulus, despite the lack of significantly calcified leaflets and trivial residual aortic regurgitation. And thus far, this patient's done well in follow-up. And I'll show you another example of a patient that we would treat with this therapy. This is a patient with an LVAD. She'd had an LVAD 4 years ago as a bridge to transplant for a dilated cardiomyopathy, and she was unlikely to receive a heart transplant. Yet she developed a problem that's not uncommon with the LVAD patients, and that's native aortic regurgitation. And this really causes a problem because of the cycle with the LVAD, and without correcting the aortic regurgitation, the cardiac output in these patients is significantly limited despite increases or trying to optimize the RPMs on the device. So she also was evaluated for TAVR, and you can see the aortic regurgitation here on her transthoracic echo. Central jet of aortic regurgitation. And her annulus measured 4.9 square centimeters with a perimeter of 91 millimeters. And we thought that she would also be a good candidate for a core valve, 34 millimeter Evolut R prosthesis. So this is her procedure, aortogram showing significant AI. Initially, the depth was too much. And at this point, we decreased the RPMs on the LVAD to help reduce some of that suction force of the TAVR valve. And then we did some pacing at 110 to 120 beats per minute, which is kind of typical for these types of procedures in LVAD patients. And we were finally able, after several repositioning attempts, to get a good position about 4 to 5 millimeters below the annulus. And you can see it probably was a little bit deeper than that when you look here at the transthoracic echo, but we didn't have any significant aortic regurgitation. And these are the patients that we would be very careful about monitoring for the next 12 hours or so to look for migration of the device as the LVAD continues to have that force pulling the valve into the ventricle. And we also keep the rates lower on the LVAD device as well. And in her case, she didn't require a second valve, but there is a significant rate of requiring a second valve in this population. And oftentimes, if that does occur, then we would use a SAPIEN valve, a 29 millimeter with additional volume, that tends to get a very nice result. So this patient has been doing very well. She had improvement in her functional status, and at 1 year of follow-up, she's doing great. Another similar case that we published several years ago was a patient who had end-stage liver disease with severe AI. We treated with a core valve, and got a very nice result, and that actually allowed him to have a liver transplant. So this, even though these are not dedicated devices and they require anchoring on the annulus, we can actually get good results if we use careful patient selection. And I'll just show a few slides of some of the clinical experience that's been published. This was one of the initial reports, a multi-center registry of 43 patients with first-generation core valve that had TAVR for aortic regurgitation. And they used 10 to 20% perimeter oversizing algorithm. And in this early experience, the results were fairly good, but there was actually a high rate of needing a second valve, 19%. And moderate or more aortic regurgitation occurred in almost 20% of patients. So in the initial experience, there was a high rate of a second valve, particularly if there was no significant leaflet calcification. A more recent systematic review of 10 case series that have been published in this population shows that with the newer generation devices, we're getting higher rates of device success. We're having less moderate or severe paravalvular leak. It's been decreased drastically, particularly with using more oversizing. And all-cause mortality has also decreased. As we get more of the novel TAVR devices, we're getting better sealing of the annulus, and I think with enough oversizing, better annulus sealing, I think we're going to get even better results, and ongoing data is coming in this area. Then we also have dedicated devices that more actively engage the leaflets and actually use the native leaflets to provide a seal. And the J valve has kind of a U-shaped anchoring mechanism here that will self-position over the aortic valve leaflets. And also the Jenna valve has kind of a paperclip type of a mechanism that will engage the leaflets and provide a seal there. And these are undergoing early feasibility studies in the US right now, and both of these have transfemoral options now as well. So in summary, TAVR for non-calcified aortic regurgitation is feasible and safe in patients with appropriate anatomy, and we're having ongoing data coming from the newer generation TAVR valves that are designed for aortic stenosis, and then the dedicated valves that I just showed you as well are undergoing early feasibility trials. Thanks for your attention.